This is an exclusive presentation of the Foreign Press Association.
Hello, everyone. I'm Ian Williams, the president of the Foreign Press Association in New York, and we're very pleased today to have a distinguished Dr. Anglea Huang, who is from the Taiwanese equivalent of the CDC. And why Taiwan? Maybe you haven't heard of it, but Taiwan is probably the safest place on the planet to be at the moment. When the time came, they recognized the symptoms in China. They didn't believe what they were told by the bureaucrats. They had their own bureaucrats who told them better. They said this was a highly transmittable disease. The Chinese government said, no, it wasn't. And the Taiwanese said, oh, yes, it is, and blocked travel from China immediately. And they asked the WHO, who said, no, nothing. Well, in fact, the WHO didn't say anything, which I think is very distressing. We will get into that later. So the World Health Organization wouldn't reply. And you have to remember where Taiwan is. It's in the middle of the South China Sea. It's in the epicenter of the virus epidemic. All around there, the place is crisscrossed with traffic to and from Wuhan and from China. So it's the epicenter of the virus zone. And the Taiwanese knew this because they dealt with SARS in times past. So they had in place a machinery, which is the first point. Secondly, they had a public health system that was equipped to deal with viruses, but this is what we want to come on to soon. And above all, they had the wherewithal and the scientific attitude not to believe what politicians told them. They could see an infectious virus when it was coming, they could see a pandemic, and they took the necessary action, which is why at the moment Taiwan is probably one of the safest places in the planet to be. And some of the credit for that, I'm sure she'd be modest about it, has to belong to Dr. Anglea Huang and the Taiwanese CDC. So what were the magic factors that has given Taiwan such an impressive safety record, Doctor?
Right, thank you so much for that kind introduction. So we currently have 393 confirmed cases as of yesterday. We have 6 that died. So our case fatality ratio is about 1.5%. So, and compare that to our neighboring countries, we're not doing too badly, but of course there are countries who are doing very well. So for example, Singapore is doing very, very well, and Vietnam has actually recorded no deaths. But one of the things that we do have to recognize is that, we're so close to China, and so having been able to have all this travel back and forth between Taiwan and China over the years, that we really were very nervous when this information came out of China. So the rumor actually came out at our time, which would have been December 30th in the evening. That's when we first saw information coming in from chat rooms in China. And the very next day, so December 31st, we started onboard quarantine of flights coming in from Wuhan. And that means we had our quarantine officers that went up to every flight that were coming directly from Wuhan, and to see if there are people who were sick, and if they were sick, then they needed to be quarantined. So a lot of our effort to be able to keep the outbreak at bay has relied on really vigorous contact tracing, quarantine of the people who are coming in from abroad, and also who are contacts of confirmed cases. And very importantly, we needed to isolate all the people who were confirmed with the cases. So that is really just the start of some of the efforts that we began to do.
And but I think the key point here is that you had the apparatus in place from the SARS epidemic. You knew what to do if you saw an epidemic, and when you saw the epidemic, the pandemic, you recognized it right away. So that puts you 2 steps ahead of most of your neighbors.
Well, SARS was a long time ago, but it's not so long that there's still people here working at the Taiwan Centers for Disease Control, and also people working in hospitals who remember and had responded during the SARS epidemic. So one of the things that are left over from SARS is that we had to we had set up laws and regulations that were put in place for stockpiles, for quarantine, for isolation, and also very importantly for hospital infection control. So for the last 17 years, every year we have tabletop exercises, and we have live in-person exercises with our hospitals, where we go in and the hospitals are reminded of how they need to what kind of questions they need to ask, and for a person who have travel history and who has suspected symptoms of the disease that is going around at the time, and how a hospital would need to transfer a patient and need to isolate that patient so that we don't have a hospital outbreaks when we have diseases like this. So that is one of the things that's very important. Some of the that's something that we learned from SARS, because if people remember, for SARS, there were a lot of healthcare workers that were infected because no proper personal protective equipment were used at that time. Another thing from SARS is that we were doing quarantine and isolation at that time, so we knew how to do that. But we needed to be reminded of what needed to be done for quarantine, and that we needed to people go into quarantine and they need to be taken care of. So, and we've done a lot better this time for quarantine. During SARS, it was the first time that we are asking people who were contacts of SARS patients that we tell them that they need to be staying home. And then where are these people going to eat? So, society has moved quite a bit since SARS. So right now, we have people in quarantine, and people can order food, get food delivered, and we also have safeguards in place that if people end up in quarantine or in isolation, they cannot work, then the government would pay them about 35 US a day for being in quarantine, just so that they do have a little bit of money if they cannot work and they don't have access to food, so then at least that they could order food, and they would have access to their for personal hygiene. Another thing that's very important that from SARS is surveillance is really, really important. So here at Taiwan CDC, we do a lot of surveillance, and that includes media surveillance. We look at not just the mainstream media, we also look at message boards, we look at chat rooms, and which is how we actually first found out very quickly when the message about this new coronavirus that was being passed around Wuhan, that actually came from a message board and from a chat room. So in addition to that kind of surveillance, we also learned that we needed to do a lot of surveillance with our viruses. So we had laboratory capacity that was built up over the years. And also for this response that, we had our laboratory protocol that was modified from the WHO protocol, and we looked at the protocol from neighboring countries and to see what needed to be done and develop our protocol based on those, so that we could do our laboratory surveillance and we could be testing for the virus very early on.
You mentioned the stockpiles that you had. What was in the stockpiles?
Well,
it certainly wasn't in the New York stockpiles, I know from personal experience here. So.
Right, so the stockpiles, we have a lot of the personal protective equipment, but even when we have stockpiles, it's never enough, and especially when we're looking at this response, we're looking at having a response that's long term. So we're not looking at having a stockpile of a month. It really is not enough for this response. So even though we did have a stockpile of masks, of personal of our gowns and these protective suits and masks and face shields, it's simply not enough. So even though we did have that stockpile, when we learned about this virus, this novel virus that's going around, we needed to take inventory and really look at how much we have and how much we may need. And even to this day, we're continuing our procurement because this response is going to go on for many more months.
Well, in some countries, like the United States, it took several months before anyone said, whoops, we must start making these things. They might be needed. Did you have a sort of logistics chain in hand where you had designated factories to produce this type of PPE ready for an emergency, even if you didn't have the stockpiles to hand?
Well, you know that what you're talking about really was for our masks. Since SARS, a lot of people learned that, to prevent disease, especially to prevent passing the disease on to others, we needed to wear a mask. So when the general public heard about the novel virus that's going around, people flocked out and bought up all the masks. So the government needed to very quickly step in and stop people from hoarding. And also people hear about this thing in China, so they started, buying masks and sending them abroad. And, and there was just not enough production to keep up with demand. So the government had to step in. So, we had to ramp up production. We had to coax these factories to start making more masks. And we had to stop the exportation. So if people needed to bring masks out of the country, there was a limit. And we also had to limit the number of masks that people can buy here in Taiwan. So, and that's just for masks. But there are so much more to PPE. Mask is used not for the general public and in hospitals. But in hospitals, we also need these protective suits, and we need gowns, we need masks, these face shields, and N95 respirators. And that, needed to have the government needed to step in and to take inventory and to understand how much do we have and how much do we need, and how are we going to distribute that to the hospitals that really need them.
What about the sort of higher level equipment, like the ventilators? Did you have an adequate stock of that, or was it? I mean, it seems to me that you were most successful in avoiding the need for too many ventilators, which seems to be the secret here. But in the end, you do need equipment like this. And did you have a stockpile? Did you have means of procuring more?
Well, right now we are looking at our existing machines that are available. So, we have machines that were lying around that are not being used. So we're taking inventory of those, and we also take inventory of these machines that, they may be old, but that hasn't been thrown away. They may need some fixing up. So we're taking taking inventory of all those things and looking at where we do have machines that if we need them, we can get them into use. So, but hopefully we won't get to that point.
Well, inshallah, as they say in some parts of the world. You have, you also in Taiwan, you have an unrivaled public health system with unrivaled records. To what extent was your database and the fact that it is free, pretty much free access to everyone in the country, how much did that help in getting people to seek and benefit from medical attention?
So you're talking about our national health insurance system.
Indeed, I am. Yes.
Right. So our national health system is used by almost everyone. So we estimate about 99% of the population is enrolled in our national health insurance system. And as you understand that this is government-based, so single payer system. And, people complain. People are going to complain whenever we need to pay things. But, when it comes to a outbreak like this, people, at least they don't feel like they cannot go to the doctor. So, if I feel ill and I feel like I need to go to the doctor, go to the clinic. We pay very little out of pocket. So if I were to go to a clinic, it would cost me no more than about 10 US to get treated in a clinic. But if that clinic refers to me to a hospital, or I feel the need to go to, I feel ill enough that I needed to go to the emergency room. Most people don't walk out of the emergency room with tests being done. We probably have to pay about $25, 30 US, at most 35 per person for an emergency room visit. And people don't feel, that 35 US is not a small amount, but most people, the general public, do feel like they could seek medical help for that. So it's not so cost prohibitive that people are waiting until they cannot breathe anymore before they will go to the doctors. So, and right now, and because of our national health insurance system, people do go to the doctors, and so that's one of the things that's that may be helping with our surveillance, because when they go to the hospital, and if they get tested, if the doctors suspect that they do have COVID-19 and they get them tested, the patient would actually end up hospitalized because they are suspected to have COVID-19. And being isolated in the hospital waiting for test results is not going to cost too much more for the patient. So, most patients can comply with that sort of order.
What about the availability of tests? Because that's been a very contentious issue in Britain and the United States. One of our colleagues from the Overseas Press Club here in New York was told that she couldn't be tested even though she had manifest symptoms, because she hadn't been in contact with anyone from China, so they weren't going to treat it regardless of the symptoms, because they had a bureaucratic checklist of what it could and couldn't be. And this was because they were short of tests and didn't want to, they restricted them with basically bureaucratic rules.
Well, we understand, some of these, early on, why there were such restrictions. So for Taiwan, as soon as we learned about the sequence, and, when that was published, and the WHO protocols that was published, and also our neighboring countries that had done tests, once we developed that protocol, we started running them at our central lab. And once our central lab is sure of how that our protocol works, one of the first things that we needed to do was to make sure that we can ramp up testing. So we have what our contract laboratories that Taiwan Centers for Disease Control have been working with for quite a number of years, and they are based in our teaching centers, our teaching hospitals. So these hospitals, they got involved. So, we make sure that at least our teaching hospitals can conduct these tests. And once those are, once the teaching hospitals can do the test, then we start to expand them to the other hospitals. So right now we can probably do about 3,000 tests a day. So, it's not a huge number, but our population is a lot smaller than the UK, and definitely compared to the United States. So 3,000, we're not quite running at capacity yet, but we're still increasing our laboratory, the number of laboratories that could do the tests, because a lot of our tests right now is it just takes a lot of manpower to run all the tests right now. And, some of the laboratories are running almost 24 hours a day. And, it's not feasible long term. So we are still looking at other ways where we can maybe automate it so that we could run more tests using less manpower. So that is with testing. And we need to have tests. And also we needed to have a way of letting people know who gets to be tested. So like you said, at first our case definition was that you needed to have fever and you needed to have pneumonia and you needed to be coming in from Wuhan. But that case definition got expanded very quickly as more information came out, when we realized that this thing is not just in Wuhan. So we needed to expand our case definition. So if you were in China, then then you can get tested, and then we need to expand it to if you were in Europe or United States, right? And people needed to test it. And fever is also another thing. Very as fairly early on, we were realizing that, from all the published information from China, that, they were indicating not everybody had fever, which is very different from SARS. During SARS, it was very clear that people had high fever. And it was very clear that people didn't pass their disease on to others until they had fever. But with this new coronavirus, it's different. A lot of people didn't start with a high fever. They may have we've had diagnosed quite a number of people, they did not have high fever. They had maybe a little fever, and some of them, a little cough, a little runny nose, and that was the main symptoms that they came with. So we had to expand our case definition, to include those people, so all those people could get tested. So right now, our case definition basically, if the doctors suspect them to have COVID-19, they get tested if they wanted to. So.
Is there have you observed any connection between fever and outcomes? Do people with fevers have worse outcomes than people without fevers, or?
That information is not that clear right now. We have people who come in and, they may have been contacts of a confirmed case. So they get tested, and once they develop any sort of symptoms, so they may have a little bit of cough, but because we know this person is a contact of a confirmed case, and so we test them. And so that's the symptom at the start. It doesn't mean that they don't develop a fever later on. And so that is the kind of information that we still need to gather. We just don't know enough about this virus yet, and how the symptoms progress. We certainly don't have enough information here in Taiwan, and we haven't seen that sort of association between certain symptoms and their outcome.
Do divert if this gets too, I wouldn't say political, but to what extent have you had cooperation from the WHO? Initially, they didn't respond, I gather, when you asked for more information and passed on your suspicions about how infectious the new virus was. Has there been any cooperation since then?
Well, when we first found out through the chat rooms and these message boards about this, new virus that might be happening in China, well, the first things that we did was to let WHO know and say, and ask WHO, have you heard of this? And is this true? And we also needed, but what we got in the reply was, yeah, we passed this information on. So we have been involved in some of the teleconference, and but most of the information really, how WHO arrives at certain decisions, a lot of that information we really are looking at what's published. So, WHO does a very good job in publishing all their guidelines and all their protocols. So we do look at the WHO guidance for that, but we do try to play our part at passing information on to the WHO, or actually through the our IHR focal point. But that really is our way of playing a role in this international health community, because, very early on, we were seeing cases, that might have been, that might have contracted disease from Italy and from other parts of the country, even before, and so that we needed to inform these places of what we are seeing. You know, even if countries may not think that the disease were contracted in their countries, but we needed to inform through the IHR focal points so that these countries know that you have people who were in their country and is now diagnosed with the disease.
Well, there does seem to be a lot of politicization of verdicts. Oh, we couldn't have people ill here because it belongs in another country. You know, so they must have brought it from somewhere else.
Right. Well, it's, you know, we always need to be vigilant, and you know, because Europe is so far away from China, and you know, sometimes we forget how small the world is when we're traveling on plane. You know, we can go around the world in, you know, less than a day, and so viruses travel, and people travel. So you know, we just don't know when a new virus can pop up somewhere else. So we need to keep each other informed.
Have you done any in-depth research on the nature of the virus and even the origins? Are you prepared to discount some of the wilder conspiracy theories that it was manufactured, or is it?
Well, you know, we don't know enough about it. There's still a lot of unknown. You know, the world has reacted so much faster this time around compared to in 2003 when we had SARS. But as fast as we're moving now, and as fast as we have been able, or China has been able to identify this new virus, we just don't know enough about this virus yet. So a lot of that information just needed to be, we just need to wait until more research is being done and more things are published.
And your labs haven't seen any signs of mutation in the virus. It's not developing like a cold or a flu virus with rapid mutation.
We're not at this time. We're not doing all that kind of research right now, because our for the Taiwan CDC lab, our focus really is in diagnosing everyone. And you know, if we do have additional manpower later on, we might be able to do more sequencing, so we can know how the virus is evolving. But at this time, we're not doing a huge amount of sequencing and looking at possibly origins or mutations. Not at this time.
Mm-hmm. Are there any other countries that you are in contact with, advising, providing material and intellectual assistance on the virus?
Well, I can't say that we're providing assistance. We're certainly always happy to share our information if countries contact us. But you know, I think we have to be very humble. We might be doing very well right now, but that is today. You know, things can change very quickly. There may be pockets of diseases that we're not finding, even though we do have extensive surveillance. We cast a extensive net for surveillance. So, but I think we just have to continue what we're doing right now and really think ahead of what else needs to be done, and plan ahead of, you know, what happens if I do have more and more widespread local spread of disease. But you know, at this time, I cannot say that we're providing assistance, but I certainly think that we need to be humble of the achievements that we have been able to see and we've been able to do. But I can't, you know, there's no guarantee, no country can guarantee that things are not going to change quickly. And, you know, so we just have to keep doing what we're doing.
In the light of your experience, is there anything now that you would have done that you didn't do?
Let's see. Well, you know, I think some of the things that we can always do more. We can do more contact tracing. We can test more. You know, we can get more people into the system where we're not our public health workers are not, working without any breaks. So I think, in hindsight, we can always use more people in public health. I've heard people say that public health is more like a fire department. So we need to be here. But when things are going well, people don't realize the need for public health, and we don't realize. So when there's no fire, we don't realize that we need a fire department. But a lot of our work is in prevention. So we're hoping to prevent diseases like this from happening. And when diseases like this happens, we hope to prevent them from very widespread. That we can prevent deaths, we can prevent morbidity and mortality.
Jonathan, have you got any questions in there? Do you want to jump in? Nope. Let me check. There were other questions that came in.
Well, we've had we've had a little bit of trouble with our live stream, so we haven't. We luckily have this on camera or on recording, so we have those that I think we've very much covered all of the questions that were submitted already. Do you have any other questions, Ian? Do you have any of those from our list that we'd like to go back to? But I think we've actually covered most of these.
Unless we sound partisan, one of the questions was, what advice would you give to the US? It would be a bit presumptuous to say, would you recommend single-payer healthcare to the United States? I wouldn't want to drop you in here with a question like that. I'll just leave it hanging there in the air for people to draw their own conclusions from what you've said. But I think we have pretty much covered the questions that did come in. Just on epidemiology, all of this stuff about herd immunity. Herd immunity seems to be developed. It seems to be more of an ideological than a biological or scientific concept, or at least the way it's used. Do you have? Is this part of the Taiwanese planning?
Well, the way that we're doing things right now, so people understand the concept of herd immunity is that if everybody gets infected, or if we have a certain percentage of the population who had developed antibodies, so that then we wouldn't be able to pass on the disease. And that has worked for measles, that has worked for polio. But for the SARS-CoV-2, for COVID-19, this new disease, I don't think we know enough about it right now. So there's a lot of work that's being done to see if and when and how people are developing immunity to the disease, and if that immunity lasts and how long that lasts. But we're just so early on in this epidemic that I don't think that we know enough yet. So, but here in Taiwan,
there have been reports of reinfections. We don't know whether this is because of faulty testing and faulty diagnosis, but from across the world, there have been several reports of cases of reinfection, which
so exactly. So there's been lots of different reports, and so at this, I don't think we can really draw any conclusions at this time. We need to have more reports of how people fare after they are discharged from the hospitals or after they have recovered. So at this time, we just don't know enough.
I think it's early in the morning for you, and it's late at night for people here. We don't want to destroy people's immune system with sleeplessness. So I have to thank you very much for a comprehensive briefing explaining Taiwan's response. This is Ian Williams, president of the Foreign Press Association of New York, and I've been talking to Dr. Anglea Huang, who is with the Taiwanese CDC, previously with the US CDC, I see, and giving a comprehensive briefing on the outline of Taiwan, which, as I repeat, as she's too modest to say so, is probably one of the safest places to be in the world at the moment. but they won't let me fly there. They've stopped the flights. So, but thank you very much. I look forward to seeing you again soon. Thank you, everybody.
Thank you very much.
And this is the Foreign Press Association. Look us up, FPA.org, and you will find out more. We will continue our comprehensive series of different aspects of the coronavirus epidemic. As you're all locked down in New York, we have a captive audience. We're taking advantage of it. Thank you very much again. Bye, Dr. Angela.
Thank you.
Thank you for joining us for this broadcast. To learn more about our digital forums and programs, please subscribe to our YouTube channel. For membership information, please visit www.foreignpressassociation.org and on Twitter at FPA New York. This has been an exclusive presentation of the Foreign Press Association.